Hello, everyone. My name is Gabriella Wicker, and today I will be sharing my research titled Killing Fear, Birthing Black Babies, which sought to understand the relationship between maternal health literacy and the desire to have children amongst collegiate-age Black women. This research was conducted under the supervision of Dr. Shantoya Jones, a faculty member in the Xavier University of Louisiana Psychology Department. Here is a quick overview of today's presentation. I'll begin with an opening question, followed by an introduction of the topic. I'll touch on the research question and hypotheses for this study. I'll go into a literature review, followed by the methodology and results of the study, and we'll conclude with a discussion and conclusion. I'd like everyone to look at the women on the screen. What do you notice about them? Can anyone identify any of the women on this screen? Starting on the left, we have Dr. Shanice Wallace, who was a pediatrician from Indiana who died due to complications of preeclampsia in 2020. In the middle, we have Shaeja, who was a beautiful Black woman from Brooklyn, New York. She died from cardiac arrest during a C-section procedure in 2020. Finally, on the right, we have Christine Fields, who was another beautiful Black woman that unfortunately bled to death as a result of miscommunication between the medical professionals performing her C-section. The tragic stories of these women are, unfortunately, more common than many people know. According to the Centers for Disease Control, maternal death is defined as the non-incidental death of a woman during pregnancy due to mismanagement or natural causes. In a national report, the CDC stated that Black maternal death rates was around 69.9 deaths per 100,000 live births. This statistic tripled the rate of white women's maternal deaths. Many Black women do not have access to proper maternal health care resources. Maternal health literacy is not included in the sexual education curriculum in the United States. Most young women get their maternal health knowledge from family members and friends, which may lead to them growing up and facing trials during their pregnancies due to misinformation. Knowledge of these trials may lead some Black women to decide against having children, lowering the Black birth rate in America. How do we make sure that Black women have increased maternal health literacy and a desire to potentially have children in the future? Exposure is key. This leads to my research question. Is there a relationship between the level of a Black woman's maternal health literacy and her desire to have children in the future? My null hypothesis is that there is no relationship between a young Black woman's level of maternal health literacy and her desire to have children in the future. My alternative hypothesis is that there is a relationship between a young Black woman's level of maternal health literacy and her desire to have children in the future. So let's begin with the literature review. Low health literacy, also known as LHL, disproportionately impacts Black Americans, with 58% scoring basic or below basic on the National Assessment of Adult Literacy in 2003. Trust, or lack thereof, in the healthcare system is a major factor contributing to LHL. When Black Americans recall events such as the Tuskegee syphilis experiment or the case of Henrietta Lacks, feelings of anger or unease may arise. When distrust occurs, it can lead people to stop seeking information from the proper sources and continuously spread misinformation amongst themselves. It's safe to infer that if the general health literacy rate amongst Black people was low, then the rate of maternal health literacy, a more specific subgenre of health literacy, is equally as low, if not lower. So how do we define maternal health literacy? Maternal health literacy is the ability of a mother or mother-to-be to find, use, and take advantage of information and resources that will positively impact their own health and that of their child or children. A study conducted on low-income rural women who were both white and Black with high-risk pregnancies tested women's maternal health literacy before and after receiving regular care visits from a registered nurse. The study concluded that these women had significantly higher levels of maternal health literacy once receiving a maternal health resource via the registered nurse and her visits. When doing initial research for my literature review, I came across a multitude of amazing resources available to pregnant women in today's day and age. Two of these resources were doulas and perinatal support. Doulas are individuals trained to provide emotional and physical support to women and their partners during all stages of pregnancy. A qualitative study from 2006 provided insights on the benefits of receiving care from a doula, such as parenting advice and confidence building, as well as affirming care. The women's husbands also noted that the doulas were an amazing support to them in the same ways. Perinatal support services ease participants' transitions into motherhood by reducing the effects of social isolation, stress, and uncertainty. A holistic care organization, Birthing Beautiful Communities, was studied to determine the impacts of the services they provided. Something that stuck out to me while I was reading this study was that 2/3 of the women who participated did not know what a doula was before attending Birthing Beautiful Communities. Most women getting care at this facility were Black women. So this really spoke to the need for programs and services that increase maternal health literacy in the Black community. Unfortunately, there are some barriers that hinder Black women from getting improved health literacy. From 2018 to 2020, 64.8% of Black women's births were covered by Medicaid. At the time of conducting this research, Medicaid did not cover the cost of doulas, perinatal support services, or other maternal health care resources, although I am sure there are advocacy groups and politicians working to change that policy. Many Black women simply do not have the means to pay out of pocket for the life-altering maternal health services I've touched on in this presentation. Lack of accessibility for affordable health care is a huge barrier for increased maternal health literacy and improved maternal health outcomes. While looking for studies on the desire to have children, much of the literature I found or had access to came from different countries. One study I found that was conducted in Iran discovered that significant factors contributing to women's low desire to have children included employment opportunities, marital satisfaction, and social support. The women noted that they did plan to have children within 2 years of participating in the study. So how does this all tie together? The literature I've discussed in this presentation and my paper support the need for further research to be done on Black women's maternal health literacy and desire to have children. By conducting this preliminary study amongst collegiate-age Black women, I hope to open up the door for more studies to be done and new policies to be created to increase maternal health literacy access in the Black community. So let's step into the methodology. Starting with the population. Participants were anticipated to be Black female students attending Xavier University of Louisiana. All participants were expected to be enrolled in at least one psychological science course when participating in the study. Demographic information, such as classification, sexuality, and religious affiliation, was asked as well. As far as sampling goes, participants were sampled using the SONA Systems platform. The SONA platform is available to all students enrolled in psychological science courses. Participants were expected to sign themselves up to participate in the studies. Going into the instrumentation, the first scale to appear in the study is the Maternal Health Literacy Inventory in Pregnancy. This scale includes 4 subscales, and while I did use 3 of the 4 subscales on the survey, I will only be doing data analysis on the Maternal Health Knowledge Scale. I'll explain this further in the discussion section. The second scale to appear was the Desire to Have Children scale, which consists of 10 questions on a 6-point Likert scale, with the goal of measuring the intensity of participants' desire to have children in the future. All of the scales were uploaded onto the Qualtrics platform for participants to utilize. The data analysis method was a linear regression that determined the strength between maternal health literacy and the desire to have children. To test the significance of the relationship between maternal health literacy and desire to have children, an ANOVA was conducted on Microsoft Excel. Going into the procedures, participants first signed up for the study using the SONA Systems platform and were redirected to the Qualtrics study. Participants read the informed consent and chose whether or not to continue with the study. I'd like to note that participants who did not consent were automatically sent to the debriefing section, meaning they did not answer any of the questions on the survey. Next, participants completed the demographic survey. I'd like to note that participants who identified as men or male were automatically sent to the debriefing section of the survey, meaning they did not complete any of the survey questions. Participants then completed the 3 sections from the Maternal Health Literacy Inventory in Pregnancy, followed by the Desire to Have Children scale. And when participants finished that, they were provided a debriefing, which included information on what the study was about, what I was looking for, and provided some resources at Xavier University of Louisiana. So let's get into the results. Starting with the population, there were 39 total participant signups, although only 35 participants' data was used. Ages ranged from 18 to 22. There was a very high variability in spiritual and religious affiliation, with 54% of participants identifying as some form of Christian, 17% of participants identifying as spiritual and not religious, and 7% of participants identifying with Islam. There were also participants who identified with Taoism, Catholicism, and Sikhism. Sexual orientation was also very diverse, with 61% of participants identifying as straight or heterosexual, 15% as bisexual, 7% as lesbian, 5% as gay, another 5% as pansexual, and another 5% as queer. And I wanted to point this out mainly because sexual orientation and religious affiliation can play a huge role in one's relationship with pregnancy, sex, marriage, all things that have to do with maternal health literacy. There was also some variability amongst the participant classification data, with 34% of participants being sophomores, 29% being juniors, 20% being freshmen, and 17% identifying as seniors. In the demographic survey, I also asked if participants had ever been pregnant and if they had ever given birth. Only one participant answered yes to both questions. Now let's get into the numbers. An alpha level of 0.05 was used for all statistical tests. Statistical tests were conducted and graphs were created using Microsoft Excel version 16.84. A simple linear regression analysis was used to test if participants' desire to have children could be explained by their level of maternal health literacy. Composite scores from the maternal health knowledge subscale and the desire to have children scale served as the variables for the regression. Participants with missing data were excluded from the data analysis. For the purposes of hypothesis testing, a significant F lower than 0.05 indicated that the null hypothesis could be rejected, and the statistical test was relevant for the data. The Pearson correlation coefficient was 0.607, and the significant F statistic was 0.000111839, indicating a moderately strong relationship between the two variables, as can be seen in Figure 3. The result of the regression indicated that maternal health literacy explained 36.8% of the variation in the participants' desire to have children, which was significant at the alpha level of 0.05. In Figure 5, we can see that the significant F statistic is lower than 0.05, meaning that the hypothesis could be rejected. Now, let's get into the discussion. I'd like to start by first touching on the bias. As a Black female researcher who has a desire to have children in the future, the bias I have is toward participants with the same desires as myself. Since the research was done virtually through surveys, the bias I had did not interfere with the participants. Now, getting into the ethical portion, any damage to participants' mental, emotional, or physical state had to be considered, even though the research was done through surveys. To alleviate participants of mental, emotional, or physical anguish, a list of resources for mental, emotional, physical, and sexual health at the University of Louisiana was provided in the debriefing section. So, getting to the limitations of this research. On the survey, there were 3 of the 4 subscales utilized from the Maternal Health Literacy Inventory in Pregnancy. However, upon review of my questions, only one subscale was needed to be analyzed, which was the Maternal Health Related Knowledge Scale. In the future, I would consider using more of the subscales depending on the population of Black women being surveyed. When the data was transferred from Qualtrics to Excel, there was an instance of an individual being repeated twice. This individual had no results for any of the questions and therefore was removed from the dataset. One of the most prominent limitations with doing research via the SONA platform was participant interest. Many participants signed up for the study in order to receive credit in other psychology courses. This meant that participants may not have really been interested in the questions being asked and could have just been answering at their own whim, which could lead to false data. And finally, the existing literature surrounding the topic of maternal health literacy, specifically for Black women, was very, very scarce. The desire to have children literature was also scarce in the United States. Moving forward, I would have to gain access to different scholarly journals in order to have a wider range of literature options. As for my conclusion, the implications of the research are vast. Further research on this topic could support educational policy changes in all public schools, possibly mandating maternal health information to be taught or dispersed in high schools. There are also possibilities in the public health space. Organizations and nonprofits could work to create easily accessible maternal health resources, host workshops, or even create clinics focused on maternal health of Black women, which is something I'm interested in doing in the future. There is also room for the care of Black women in hospitals to be revamped and made more equitable. The possibilities surrounding this topic are endless. Moving forward, research should be conducted on Black women of different ages, geographic origins, and socioeconomic statuses, as these factors may also contribute to maternal health literacy and desire to have children. Thank you all so much for taking the time to learn about the research that I conducted. This was my first time conducting research, and it surely will not be my last. I'd like to open up the floor to any questions or comments, even feedback, and I've left my contact information at the bottom of the presentation slide as well. Thank you all again, and I hope each and every one of you has a blessed day.